next talk is going to be predicting scoliosis curve progression, what we are learning from 3D, and a true expert in this, Stefan from Montreal. Thank you.
Hi, I'm the North version of North America. I'm from Montreal, and unfortunately for you, my first language is not English, so I apologize. Sometimes when I do a scientific talk, I can read something off a paper, but sometimes when I have to do more ad-lib stuff, it's a little bit more difficult for me than all these other esteemed faculty. And then going after Michael is usually very hard because he has all these pictures and nice cartoons. I'm a little bit more bland, or bland. But it's the reason I'm presenting this, and the reason I did this research is that I was taken with a paradigm in clinic. So I had a difficult choice to make, or it was difficult to answer the question that you had. So patients come to me out in my office, and very early in my career, I was having the difficult decision to tell them, I don't know what's going to happen with your curve. So these two patients are very similar. They're different, but they're similar. They have different, very similar curves, patterns, and they're about the same age. And they're in your clinic, and you're faced with the decision to say, well, I don't know what's going to happen, and the best evidence that we have is that we can brace you, and if that doesn't work, then we can go to surgery. But it's really hard for us to tell you the first time when you're in clinic what's going to happen with your curve, and that comes with a lot of distress. This is the regular treatment algorithm that we have out there that we use in clinic. It depends on how severe the curve is, how much growth remains, but it always goes through observation, bracing, and eventually surgery if you go to that extent. But we know there are certain things we know. The younger you are and the bigger the curve you have, the higher the risk is that you will progress. So a young patient with a big curve is more concerning to me than an older patient with a small curve. But this, I mean, that's often after the fact, right? If you're 15 and you have 12 degrees, then your likelihood of having a big curve is small, but we're almost done growing, so that's kind of a given, right? But if you're 12 and you have a 25-degree curve, maybe it might not be so easy for us to predict how your curve will behave and how it will grow. So there's two classical studies before the stuff that we did in 3D that looked at this, and they both came, after looking at a bunch of patients, they came with the same conclusion. The bigger the curve you have when you present, and the more growth you have in front of you, the more risk you have to go to a larger curve and having a surgery. But that was something that was kind of but they came up with those normograms, and same thing for the second study. The bigger the curve at presentation, the higher the risk of progression was, and the younger the patient was, the higher the risk of progression was overall. The issue is that if you look at these two patients, one of them stayed about the same, and we're talking the same. So the first visit, they're very similar, but one stayed about the same, but the second one went on to progress and have eventually surgery. So, and there's nothing, at least a couple of years back, we didn't know what we could use to better predict this, but we've tried to better understand this. So risk of progression is important for treatment selection, early detection of curves at risk of progression, but also early detection of curves that will not progress. Because if I was able to take off, and I'm not advocating not using a brace, but if I could identify patients that will not use or will not benefit from a brace, I won't subject them to this. So we're trying to really try to identify early these patients to try to first identify those who will progress, but also who will benefit from a brace or not benefit from a brace. So at first visit, it remains a challenge. It comes with multiple clinical visits. You need to have serial radiographs, and I see the EOS people in the back. They have this machine where they decrease the dose whenever we do an X-ray. So we're having less dose every time, radiation dose every time we do an X-ray than maybe 10 or 15 years ago. But it's still radiation every time you have an X-ray. So if you have an X-ray every 6 to 12 months, that's added. So if we find ways of decreasing that, that's better. And it has some psychological stress. And you're always asking, why is this difficult? Well, kids are going through a phase where they're changing, right? So, and I like to compare my patients to little butterflies. They come in very young, and they go through the cocoon, which is the brace, and then eventually they come up as a butterfly at the end. But it's a difficult process, and it's a time where they're changing, and they don't necessarily like to be there, and the negotiations for a brace is often very difficult. And as a surgeon, they look at me and they say, "What? You don't know how my curve is going to behave? Are you crazy? Didn't you go to school?" So it's a little tough for me to engage with these at that point. So just to give you a quick historic perspective, why 3D? So why are we using 3D? Well, if you look at these two patients from the back, if you look at them, this is something that we can get from these two images that we do. We can do a 3D reconstruction. And these two patients look pretty much the same. But when you add the side view and the top view, they're really different. When from the top, you can see that these two patients will not behave the same in a brace or in surgery. So these two patients are very different. So today we can use a 3D reconstruction with the EOS system where we get two images at the same time, and we can then reconstruct them in 3D. And then what we use that information for is that we can use that personalized geometry. So you can use that 3D reconstruction that is from your child or or the patient itself, and use this to try to better predict what the treatment will have as an impact on us, and how they will react to a brace, how they will react to surgery, and even try to determine how these patients will progress over time. So again, two patients, very different, two different type of curves. One went on to surgery, the other one did not progress. But then again, these two patients are different in 3D. So what we tried to do is that we looked at historically perspective parameters, such as the Cobb angle and the age at presentation, and we tried to add 3D parameters that were personal to every patient and add this to the model and try to see if we're better at predicting scoliosis progression. So we went on and did the study where we had 200 patients recruited at our center, prospectively followed them so that we followed them in time just to see how they would behave and see what their progression would be. And we didn't change anything. We just used bracing, and we went on to surgery if they needed to go to surgery. But we tried to determine if at the first visit we were able to predict what would happen to their curve in the end. And then, and we looked at a bunch of measurements. So once we had the 3D model, we can measure angles, rotations, how the shapes are different and all that stuff. And we can try to put this in the algorithm and try to get a better sense. So we looked at about 200 patients, and we followed them until they were fully grown. So 3 years from the first visit to the last visit. And now we can look at this retrospectively, and we're able to explain about 70% of what's happening, and we're just by adding a few of these measurements. So how much rotation is there in the spine? How much is it out of the plane of normality that Nathan showed us before? So how much rotation of the spine is there? And then how much apical vertebral rotation is there? So how much is that apical, like the maximally deformed vertebra, how much rotation is there in this vertebra? And then how much are the discs, because there's bone and then there's disc, and how much are these modified by the scoliosis or not? So if you look at the historically parameters that we use, so big curve, age, this explains about 50%. So we're right about 50% of the time on how good we're at predicting, which is kind of throwing up, flipping a coin, right? But if you add just 3D for one patient, that goes up to 70%. So we're making that huge jump ahead. It's not perfect. We're not predicting everything, but we're making a huge leap because you're better at predicting how the patient will behave at the first visit. But when we add the second, the third, and the fourth visit, that goes up quite fast. So we're better at predicting scoliosis in the long term. So does it work? It's a good question, right? So these two patients are part of the cohort. The first one, the model predicted 29 degrees. The second one predicted 50 degrees. At the first visit, not while we're going. And that's what the result was. So we're right on for these two patients. So the first one had 29 degrees and the other one had 51 degrees. So at our institution, we're trying to better predict scoliosis progression. We have this multi-center study, of which many in the room are part of, where we're collecting patients and trying to validate that model, to give this back in the hands of the surgeons, and then try to better predict scoliosis progression. So we think that with this new model, we'll be able to not only identify patients at high risk of progression and try to give them a better treatment earlier. So if we think that the personalized brace is going to be better for them and they're going to be reacting to this, then we'll be more aggressive in terms of you should wear this brace. And if we have patients that will, no matter what, go to surgery, then we might intervene a little bit earlier to promote some non-fusion devices. Thank you very much.